All right, you guys can see this?
Yeah.
Yes.
Yes,
All right, cool.
very zoomed in now.
Yeah, that was intentional. So we'll do a quick talk on CRRT side. I don't know if Dr. Kumar is there, Malika, but Dr. Kumar, if you're there, please do chime in. I'm sure you have a lot more to say than I do. So this is supposed to be a quick primer on CRRT, continuous renal replacement therapy. We'll spend the next like 20-25 minutes kind of going over some basics, things that we should really know. And then the more advanced stuff, we'll do like a quick Q&A with Dr. Kumar. And then, in the meantime, if you guys have questions, definitely go ahead and ask them so that way we can get kind of all the stuff out of the way. And what I really recommend doing is thinking about some of the tough situations you've had, especially your critically ill patients that we've been running on CRRT, and then we can kind of go from there. So really what I think continuous renal replacement therapy, I'm thinking about like my basic stuff. So, like our usual indications for dialysis, right? So A, E, I, O, U. So we're thinking like acid-base disorders, electrolytes, volume overload, uremia, and then ingestion of like toxins. And there's obviously a lot of toxins that we think about. I know some places you go to, you'll never come across like foreign toxicity. We see it here way too much, but there's a whole list of toxins that can be cleared renally, and then for that there's different indications. Now there are some centers that will not be able to do CRRT because that requires a higher level of care, and there are some centers that will only do CRRT. And the reason why we should be very familiar with CRRT is because it's specific to the ICU, and there's a lot that can go wrong with it, both hemodynamically and physiologically. So when we think about like what we're really trying to do is we're trying to do continuous renal replacement therapy versus intermittent HD. And in both cases, what you're trying to do is you're trying to mimic the physiology of the kidneys, right? So when we think about like the physiology of the kidneys, we have these like, you have your glomeruli with the afferent arteriole coming in, you have the glomerulus here, you have your efferent arteriole, and then there's like this whole like trabecular system where it interacts with the loops and then goes along its way. And there's different ways that it works. And when we create this whole system, we're trying to mimic the exact same thing. And so what is the system that we're creating? Well, when you really break it down, let me just quickly change it so it's easier. 1 second. So my preset colors. All right, cool. So when we think about a system, you have your patient. And then you, at some point, are going to get an access line in, right? Yeah. All right, let me start that over. All right, so at some point you have your patient. And you're going to get an access line in. Things to know about your access line is that you are going to have 2 ports, right? I mean, yes, we have we use dialysis, so there's that third extra port to administer meds. But when you think about the anatomy of a dialysis catheter, usually your double lumen dialysis catheters, you have an access port by which way you are getting blood. And that is going to be somewhere a little more proximal than your end. And then you have a return port by which way you're going to give blood back, and that is a little more distal. The reason why we do it this way is that we want to not withdraw blood from the area that we are giving blood back. Does that kind of make sense? Otherwise, you start running into like those high pressure lungs, having issues that way. And then this blood is going to go, this blood is going to go down into a pump. And this is your access blood. And then this is going to go to a filter. One second. It's going to go to a filter, and then that blood is then going to come back into your access line. Now, other things that you have to consider is that there is going to be an effluent fluid, so that's like blood that's filtered out. This thing's lighting. You're going to have blood that's filtered out, and that's your effluent fluid. And so this is kind of like your basic anatomy of how a dialysis line works. Some of the other things that you'll see we'll kind of get into in a second, but you can have a dialysate fluid that is basically like the fluid that you're trying to use for hemodialysis, and that is going to go to your.
Uday, you want to hand that phone off to the attending?
Yeah. You're going to have dialysate fluid that's going to go to your filter. Now, in order to like kind of understand the rest of it, what you have to understand is what are the different types of way that all the methods of dialysis can work. So everything kind of comes in pairs of four. So we kind of talked about like the fluids, right? There's a few different fluids that we can use. One of them is the dialysate fluid, and then you also have blood.
They're having issues with the bed.
Tell them to call it for you.
Can you call her?
Uday, you want to hand that phone off to whoever's the attending today?
Yeah, we did.
They don't have his number.
Tell them to call the
Call him.
ED resident, Harry.
Call the ED resident, Harry.
He signed into the role.
He signed into the role.
All right, so when we talk about so here you have your blood, right? And so on the left side is your blood. On the right side is your filter, which is you're going to have your dialysate fluid running through this. What's important here is that it runs counter current, and the reason this is important is for the first property that we talk about, which is called diffusion. And what's happening is that it's all based on a concentration gradient. So you can see that here there's a much higher concentration of particles, and this is going to diffuse across the semi-permeable membrane into the area of lower concentration. So our first method that you're going to have of dialysis working is diffusion, and that's pretty much equivalent to hemodialysis. And so what's happening in diffusion is all dependent on a change in your concentration gradient, so higher to lower. And this is going to be varied by the type of particles that you have in there. The next one is filtration. And this is like what we call UF and all that. And this is also equivalent to hemofiltration. And so the way this works is that this is going to be dependent on a change in your pressure gradient. And so the way you could kind of control this is that you can adjust the flow by which you are running your blood. So you can run blood at a higher flow, or remember that there's an effluent fluid that's leaving this way. You can increase the pressure by which that negative pressure by which that is being dragged out. And so you can either have a positive pressure here by the flow, or you can have a negative pressure here based on the effluent fluid. So either positive pressure or a negative pressure that's driving filtration. What's important here is that this thing is running counter current. And why that's important is, so here you have your semi-permeable membrane. And then you're going to have blood run in one direction. And so initially you see that your blood has a higher concentration. And then as you go, keep filtering the blood this way, your concentration is going to decrease. Now, the reason why you want your dialysate fluid to enter from the other side, so you want it to start entering from here, is that initially this is not going to have the concentration of particles that this has, right? So when it enters, there's no particles. And then because of this concentration gradient, things are going to move over, and then it'll start to build up. And so you can see that no matter where you are along this membrane, that particles are always moving from the blood to the dialysate fluid, not the other way around. If you ran both of them in the same direction, then it would start off at zero, and then as this thing progresses, the concentration gradient would be much less, and thereby it would be ineffective. And then finally, the next one that you have is, convection. And the term to remember here is solute drag. So when you have a high amount of filtration going on, so you see fluid moving from this side to this side, what you'll also start to see is that smaller solutes like electrolytes and things like that will also start to be dragged across with the amount of fluid. And so then you can get a good amount of volume to move across the membrane, and the solute is pretty much dragged with it. Things to keep in mind about the solute drag is that because you're removing a lot of fluid out of the membrane, you have to eventually replace that fluid. And that's where the next fluid comes in, and that's your replacement fluid. Now, the replacement fluid can be added either pre or post dialysate, meaning it can be either added pre or post filter. And so this part was kind of confusing to me, and then Dr. Kumar, feel free to chime in on which is better, but you have this replacement fluid that you can either add before it enters the filter, or you can add it after. Now, the reason why this matters is that if you add it pre-filter, you're going to dilute the fluid more. And so when you dilute the fluid more, you're going to get less clearance. However, your filter is going to last longer because it's going to not clot up the filter as much. So you'll get less clotting if you add it before, but then you get decreased clearance. And then if you add it post, you'll get more clotting because it won't be that your initial fluid that's coming into the filter is not going to be as dilute. But because of that increased clotting, it's going to not last as long. So different places do different things, but majority of times that you'll see the dialysate being, it's a mixture of both being added both pre and post. But something to keep in mind, and really what you're trying to do here is trying to make sure that this fluid is given back. And so when we talk about the dialysate fluid, one of the things is like what's in the dialysate fluid. It really contains a mixture of electrolytes, and things that it'll contain is sodium, it'll contain chloride, it'll contain magnesium. And then the other thing that we commonly see, which is relevant to the orders, is the potassium. This is what we refer to as like the K bath. What you also see is that you will not see, uremic or creatinine. This won't be part of this. And so that's kind of like really what's in your dialysate fluid.
There you also have calcium. That's the other thing.
Yeah, sorry, that's the other one.
Yeah. So basically, those are the ones where you can change the consistency. The potassium can be anywhere from 0 to 4K, or the calcium can be anywhere from 0 to 3 calcium bath. So that's where your different combinations of replacement fluids or dialysate fluids can be.
Perfect. And then the final thing is to remember is adsorption. Now this we don't talk about as much because it doesn't change with the different methods, but it does matter when you're thinking about like the other effects of dialysis. So, when you think about like, I don't know if you guys ever heard like patients that are overtly septic, why do they get better after dialysis? You have a lot of, biologics going on that's kind of produced from your inflammatory system. Well, those biologics can actually bind and then they adsorb to your filter. And so they stick onto this filter, decreasing the life of your filter, but they will not go and diffuse onto the other side. And they're actually some filters that are developed to help increase absorption, like, that kind of like, Dr. Kumar, I don't know if you know the name of it, the cytosorb. They can actually absorb a lot of these cytokines and help patients who are overtly septic or, kind of really ill from other things. And so this is where kind of the absorption really becomes in handy. All right, cool. So if you kind of like understand those 4 concepts of how dialysis works, that kind of brings us to different ways we can kind of run CRRT. So it really is a balance between, so if you kind of like make a 4x4 table between hemofiltration and hemodialysis. And so the first method is when you're just trying to remove fluid. So in that method, you're going to have this basically this diagram. You're going to get fluid out. It's going to go into the pump. It's going to go through the fluid filter, and it's going to come back. In this method, you are not putting a replacement fluid. You are not giving dialysate. You're purely trying to remove fluid. And so that's called slow continuous ultrafiltration, or SCUF. And purely the attempt here is to do volume removal. The primary methods that you're using is, like when we talked about those 4 methods, is just HD. Is just hemofiltration. Oops. So then now what you can also do, pretend you want to get more fluid out. You also want to get rid of some of the smaller solutes, like some of your electrolytes, address your acid-base disorders. Then what you can do is that you can add in a replacement fluid. And so your replacement fluid, once again, can either be run pre-filter or it can be run post-filter. And so when you have this, you'll get that added mechanism of hemofiltration, plus you'll get convection. And this is what we call CVVH. So this is continuous veno-veno hemofiltration. Once again, really effective for trying to remove fluid at higher amounts. You don't have to remove it as slowly, but then you also get that added benefit of some removal of electrolytes, so like acid-base disorders, correct electrolytes. So then now, if I wanted to, I still haven't thrown in that dialysate fluid, right? So because where that dialysate fluid is really effective is clearance of some of the larger molecules.
A little bit here. So
Sorry, go ahead.
CVVH, basically what you're doing is you are actually dragging more fluid with the help of the pressure. So you're actually getting rid of a lot of solutes with the fluid. The problem is you cannot control how much of fluid is coming out. The patient can just get like 4 or 5 liters. So you're giving a replacement fluid to control the amount of fluid lost. So which can actually be done as a pre or post in both ways. So that is the whole concept of giving the replacement fluid, is to control the amount of fluid loss with the dialysis.
Correct.
So that is what it is. It's not that it does help you. It basically is just because if the patient loses 4 liters and you just want him to lose 2 liters, you will give 2 liters as a replacement fluid to him. Yeah,
I mean, based on what I'm saying is that you're getting much better control about controlling your ins and outs with CVVA, like continuous veno hemofiltration, because you're able to control how much fluid you're able to give back, and you're able to run at higher rates compared to just doing scuff. So the next one is that if you want to control dialysis, you want to clear electrolyte disorders, you want to clear some of those larger toxins, then you throw in your dialysate fluid, and then you run it up here at the start of this filter, running in counter current with your blood. And when you have this without your replacement fluid, this is what we call CVVHD. And so this is continuous veno-veno hemodialysis, really prioritizing just that pure mechanism of hemodialysis or diffusion. That's the primary method that you're using here. And then finally, when you have, I'm sure you can kind of figure out what's next, is that when you put this replacement fluid in, this is when you can also remove larger fluids and get diffusion. So if I take that replacement fluid and then I either run it pre-filter or I run it post-filter, then I get pretty much a best of both worlds, which is hemofiltration and hemodialysis, and that's called CVVHDF, hemodialysis with filtration or hemodialysis filtration. And this is, I believe, what most centers will use, and this is what we'll use majority of the times, because you can kind of control everything with this. And this one, you're using your mechanisms of hemofiltration, convection, and diffusion. Now, the fourth one that we talked about, absorption, these are used in all 4 of them. So with the methods, does that kind of all make sense? So our next kind of like topic that's important to kind of address is anticoagulation, right? So like, why do we talk about anticoagulation in patients that are on hemodialysis? And it's really for like the life length of the filter, because we talked about absorption. As you kind of push all these fluids through the filter, it's going to start to clot up, and you're going to get like blood products there, and that's going to ruin the life of your filter, which can be a pretty dangerous thing, right? Because when you're running blood through this filter and your filter dies off, there's a lot of blood that's like trapped in this filter. And every time you have to change out this filter, you're stopping CRRT, you're losing blood. If you do it too many times, you have to replace the filter. This is why it's very important to like properly prime these filters and ensure that you're not losing your filter. So the one that you guys probably know that we use most is heparin. And I know this varies across different institutions, so Dr. Kumar, feel free to chime in on how we do it here, but you're going to give the heparin with protamine. And so you'll run like the heparin here, and then you'll give the protamine here. So that way that heparin, this is if you're doing it regionally, you'll give it here, the heparin here and the protamine here. So that way, as you're giving blood back, you're not giving thin blood back. It's also important that you're regionally giving heparin in your dialysis lines when you're just keeping a position, and then you have to clamp them to make sure that heparin is there. And so when you're doing any type of troubleshooting, such as if you're addressing like clotting issues or pressure issues, is that you know exactly if the heparin or not has been drawn, so that you don't accidentally administer heparin throughout the entire body. The other way to administer heparin is to do it systemically. So, patients can already be on anticoagulation. They can be on it for, blood clot. They can be in it for AFib or a PE or whatever reason they're on anticoagulation for. And so this is obviously great, but the downside of that is that you obviously have a higher risk of bleeding. So we don't put patients on systemic anticoagulation just for dialysis. Keeping in mind that if you also have someone running on CRRT and you're trying to reverse the anticoagulation that they're on, that your doses of that reversal agent are going to be different than what you are usually giving for someone that's not on dialysis, because it's going to be clear. It's going to be cleared. And the other one that you can also consider is citrate. So citrate works just as well as heparin, but less of the bad effects of bleeding. And then you guys know what you have to give with the citrate. It's not a reversal agent for the citrate, but it's very similar to why we have citrate in our blood products, right? So we keep citrate in our bags of blood to prevent it from clotting up. So you have to give calcium with it. And you're going to give the calcium either regionally here, or you're just going to give it systemically. And the way you're going to trend the effectiveness of your citrate is by serially checking ionized calcium, your free calcium. Because pretend you are giving blood back, and then you go ahead and check your citrate, your ionized calcium here, and it's normal. Is that good or bad?
Get worse.
You don't want your ionized calcium to be normal, right? Because that tells me that your citrate is being ineffective. Because what does citrate do? Citrate binds to the calcium and uses up all your calcium. So when you're taking blood from the body and you're using citrate in your filter, your ionized calcium should be low because your citrate should be binding up your calcium. And so that's why we have to give patients calcium back, so that the body can use it for all the stuff that we use it for. For example, to support our blood pressure, right, by vasoconstriction. And so when you're drawing ionized calcium from post-filter, it should be low, but then in the body, your ionized calcium should be normal. And then this one, I've never seen it used, but people will talk about it in like lectures on CRRT, they'll talk about it in papers, is that you can use prostacyclins. And the reason that works is that it prevents the functions of platelet activation, but then what's the downside of prostacyclins? Is that it causes profound vasodilatation, and so if someone's kind of in that shock state, they're not going to really tolerate this well. You can also get changes in cerebral perfusion. Dr. Kumar, anything else on the anticoagulation?
So pretty much no, we only use heparin here because the problem is you need to monitor the ionized calcium very quick with the citrate, and we don't have machines to monitor it up because it's a send out test here. The other thing is, I don't think so. Over here we use heparin with protamine. We just use heparin, and we just tried. There's a titration policy, I think, where you try to keep the APTT between 45 to 80 for those patients. You don't keep them very high. So you usually start with like 500 units an hour and then titrate it as per the APTT results. So I don't think so. We use protamine with the heparin here. We only use heparin.
I know some institutions will use it, and they'll try, instead of kind of keeping that lower dose of heparin, they'll use, like a higher dose of heparin. And what they'll do is they'll just give protamine. They'll give 100 units of heparin with, for every 100 units of heparin, they'll give 1 gram of protamine, and they'll just give it post filter. But that's good to know that we don't use it here.
Yeah, up to date usually recommends either using citrate or using like a heparin with a titration protocol with the APTT.
Yes.
That's what. So we usually use that.
Cool. So with that said, what I really want to focus on next before we kind of get into like some clinical pros is if you guys are on in front of a computer, what I recommend doing is on any patient opening up the CRT order set and then kind of taking a look through, and maybe Dr. Kumar, you can kind of walk us through what orders we should be, like what orders you are entering, or what, if obviously a patient's like overnight, what orders you would want us to enter in a patient that we are writing CRT orders for.
Sure. So why don't you guys open up the CRRT orders on a patient?
And for those of you at an outside hospital, your order set's going to be different than what we have here. Obviously, we made the orders, like, Dr. Kumar and Dr. Ray made the order set here. And it's a very good order set compared to what I've seen at other institutions. Dr. Kumar, I'm on the whiteboard, so I can't pull it up here, but I know that Sai probably has it pulled up in front of you. You guys good? Hello?
Who are you asking?
Anyone? You guys have the order set? Dr. Kumar, do you want to run through it whenever you're ready?
Yeah, let me open. So the order sets, to be very honest with you, were made very easy. You guys shouldn't have much of the problems. The thing still now, and I'm still working, is you cannot, it only can be put by a nephrologist, but I'm seeing if there's a way where a fellow can write it up and you guys can send it to one of the nephrologists and they can just go ahead and okay. So if you look at the order sets, a lot of things are checked and you don't need to uncheck any of those things. Usually they're okay. So the first thing is obtain consent. So that is something where you have to talk to the family, explain to them, and if you have, then just click the right box and tell them, yeah, consent obtained from who and who, whatever it is. Okay. So the next thing that comes up is the dialysate. So when you're running CRRT, so remember one thing is when you're using your regular dialysis, the blood flows are anywhere between 600 to 800 mLs per minute. Okay. So now CRRT is a slow process. You don't use such high dialysate flows on them. So basically what you do is, as per the studies, they had looked into high dialysate flow versus low dialysate flow. So actually, yeah, sorry. Let's come on the dialysate flow rate. Sorry, I will talk about the dialysate later on. So on the dialysate flow rate, basically, if you open it up, it will give you different parameters. So as per the studies, they had studied both taking dialysate as 25 ml per kg versus 35 ml per kg, thinking that if we used a higher dialysate volumes, maybe the clearances will be better. They didn't find much of the difference in these patients. So usually what we use is a 25 ml per kg. So let's say if a patient is 100 kilos, then the dialysate flow rate you would choose is around 2.5 liters. Okay. One thing to remember is the higher your flow rates are and the higher your dialysate flows are, the better the clearance is going to be. So if you really want somebody to have very high clearances, then maybe you can choose a little bit on the higher end. Like instead of doing 2.5, maybe you can choose 3 liters or 3.5 liters for some time and go from there. So the simple formula here is just to remember is 25 ml per kg is going to be your dialysate flow rate. Now coming on the dialysate, so you could have a different combinations of dialysates. You can have a variable. You could have a variable on the potassium. You can have a 2K, 3K, 4K, 0K, 1K. You can have variations in calcium 0, 1, 2, and 3. To make things simple, we kept every variable stable except the potassium. So potassium can have a 2K, 3K, or 4K, which basically depends on the patient's potassium. Let's say if a patient's potassium is 6, you want to use a 2K bar. Patient's potassium is a little bit lower, you can choose whatever bath, but just want to neutralize it accordingly. The higher the patient's potassium, the lower the bath you're going to use. Similarly is the blood flow. You can use the parameters. Usually for CRRT, we choose it anywhere between 150 to, you can go up to 400. Regular dialysate has a flow of around 400 mLs per minute. When you are doing CRRT, you're using less flow rates. So usually you can choose an option between 200 to 250. The only reason is you're using less flow is because these patients are on pressors. So anytime you pull fluid or you pull blood out of these patients, they are going to drop their blood pressures. So for hemodynamic stability, you usually try to keep the flow rates as low as possible. So, but understand one thing, when you're keeping low flow rates, you're going to have low clearances on the patient. Okay, so begin with, we usually start around 200 or 250 mLs per minute, but then if the patient is off pressors and everything, you can gradually increase. Now, once the patient is tolerating flow rates like 350 or 400, you actually can transition them to regular HT. There's no need to continue CRRT on those patients anymore. Then your next step is your ultrafiltration rate. If you come on the ultrafiltration rate, there are three things in it. It's a negative, it's a even, it's a positive. So let's come on even. What does even mean? Even means is the amount of fluid going in is the amount of fluid pulled out. Now remember, CRRT always lags by 1 hour. So the nurse starts the CRRT, sees what the patient gets in 1 hour. So let's say with all the drips and everything, the patient got 100 cc's. We told the nurse to keep the patient even. So what she's going to do is the next hour, she's going to pull out the 100 cc. In that way, she neutralized. So remember, it's always lagging behind by 1 hour. Okay. Then comes negative. So on negative, if you say, okay, I want to make the patient 50 ml per hour negative. So what the nurse does is she starts the CRRT. She says, okay, the patient in 1 hour got 100 cc's of fluid. So in the next hour, she is going to remove 150 cc out of the patient, so that the patient is going to be negative by 50 ml per hour. The third thing is going to be positive. So positive means is like, suppose like a patient comes with rhabdo. Okay, a patient's creatinine is very high, patient is on pressors. You want to do dialysis, so you started the patient on CRRT, but you want to give the patient fluids. So technically, there is no role of giving fluids on the CRRT machine. What you can actually tell the nurses, just keep the patient positive by 100 cc. So in that circumstances, what she will do is she will calculate, let's say 100 cc's was pulled out. The patient got 100 cc's of fluid during an hour. The next hour, she's not going to pull out any, because she's going to keep the patient positive by 100. Suppose the next hour the patient got 200, then she will only pull out 100 cc to keep the patient positive by 100 cc's an hour. So remember, running normal saline drips or anything when patients are on CRRT are basically useless. Okay, because you can always manage your fluid balance with the CRRT machines. The next thing you guys always ask is,
Sorry, just to add to that too. So like when we talk about fluid balance, so like if you do have a patient that becomes hemodynamically unstable, for example, like you feel like the third spacing everything and you want to give them blood or you want to give them albumin and you want them to get that volume, then you have to let the dialysis nurse know to address that. And then don't count that as part of their drips, because you don't want them to remove that fluid that you just gave. So kind of help them through that calculation, either tell them to include or exclude it based on whether you want them to keep or don't keep that volume. For example, if they're just anemic and you just want them to get the blood products, but you want that extra volume removed, then you have to have them include that as part of their calculations.
Yeah, so that's why you have to basically, anytime you're giving any extra stuff like blood or stuff, you have to let them know if you want them to be calculated or you want that to be removed. The other thing, remember, is when you're
Dr.
treating
Kumar,
somebody. Yeah, go ahead.
what about when we want to give blood products through the CRRT machine? Isn't that possible, and is that easier?
So the problem here with the CRRT machine is anytime it just increases your chances of the machine getting clotted. That's why
We can't give it post filter, like if it's just a unit of blood.
you can give it. It's not a big, but I have to see is how quick can you run it up, because you can actually, it's not a big deal, but you have to have an attachment to it, because you can do it with the dialysis. I know with the dialysis you can run the blood quick over an hour. Okay, with the CRRT I have to check it out. I'll be very honest, I'm not very sure with it, but it should be a possibility to give it post filter. The only problem is going to be is the flow rates. If the flow rate is very slow, you have to maintain a slow transfusion rate for the blood, because remember, you cannot have a high pressure on the circuit.
I see this about to-
So that's something, but I'll definitely check it out tomorrow if it is a possibility.
Sounds good. Thank you.
Yeah. The other thing you have to remember is the bicarb drips. Like when you're starting somebody on CRRT for treating somebody's metabolic acidosis, remember, if I start the patient on CRRT now, it takes at least 5-6 hours before the CRRT actually kicks in. So what you can do is you can keep those patients on a bicarb drip during that time frame till the CRRT machine kicks in and starts correcting the acid base. And in the meantime, you can use the bicarb drip, and you can go bicarb drip at a higher rate. Like if if you're even going at 500, 600 cc's an hour, and you keep the CRRT even, you basically are pulling the same volume out of the patient. Okay, so that is why you can try to correct the acidosis with your bicarb drip when the patients are on CRRT, because volume is not going to be a main issue during that period.
So can you adjust
And
the
then
rate of the
same-
bicarb in the replacement fluid?
That's not, the replacement fluids, we don't use any replacement fluids here. Okay, ours are only dialysate.
Oh, so we are primarily running CVVHD. We're not running CVVHDF.
No, we don't do any replacement fluids. We only run the dialysate.
And then same question, I guess, if we are giving bicarb, let's say there's access issues, can we also give that bicarb continuously post-filter in that same whatever HD access we have?
I'll be very honest, we'll have to look into it. Nowadays, you guys use the trialysis catheters where have an extra port for the, so you can use that extra port, but this is something we'll have to look into, to be very honest. But we
Yeah,
don't
it's just for like the one patient a week where we have like everything running and still have access issues. I'm just wondering.
because
Yeah, if you're having access issues, you probably shouldn't be using your dialysis catheter. You should be figuring out why you're having access issues and address it that way.
no access issues in the line is like, I think they're exhausted with the accesses.
Oh yeah, then you can use your dialysis.
So I'll check that out, but usually with the CRRT, we prefer on that ports not to run anything else, but there's a possibility you can use it post filter because you're not actually affecting anything. So that is something I'll look into it this week and see what it is.
Yeah, I've used it post filter before. It's just making sure that the nurses are comfortable doing it.
Then the next thing here is your diet. Basically, a lot of these patients are intubated and stuff, so you don't put any diet orders, but technically if the patient is there in the ICU, he's a very stable, is able to eat and drink and getting CRRT, they actually need to be on a regular diet. You don't need to put them on a renal diet or a renal diet, because remember, they are going to have, when you're having CRRT, you're almost mimicking your regular kidney function. So if you put them on a renal diet, you'll actually be limiting their sodium, their potassium and everything, and then you will need more replacements. So that's why if you're choosing a diet, it has to be a regular diet. Coming on your anticoagulation. So the only two things we have is basically is either heparin we use, and there is a protocol to keep the PTT between 45 to 60, or you can use this pre-filter saline. So basically it's the same thing. What you're using the concept as a pre-filter, we put in a saline just to reduce the concentration so that the filter doesn't clot. And the same as with the heparin, we use pre-filter heparin. Now, sometimes what happens is even when the patients are on systemic heparin, okay, they can actually clot the filter. So what we do sometimes, we just tell the nurse is just run the pre-filter heparin at 500 units an hour. So don't titrate it or don't touch it. Just keep it standard at 500, and you can titrate based on your systemic heparin. So in that way, you're actually even giving some pre-filter, but you're not playing around with it. Okay. The next thing is the catheter packing. Just when you are removing somebody from the CRRT, you can actually pack them either with heparin or citrate. The citrate is when they have a HIT or HIT allergies, you can actually use citrate. Electrolyte replacements are all PRN. You don't need to touch anything. Okay, so they already are synced with the pharmacy, and they will monitor the labs and give the electrolyte replacements accordingly. Then comes your labs, is where you can choose how frequently you want the labs to be drawn. Do they want them Q6 hours, Q8 hours, and what labs do you want? The nurses can draw it accordingly. With the CRRT orders, unless and until you make any changes, you can continue with the same CRRT orders. Usually the only changes that come is the fluid management. You want to remove the patient 25 cc's, you want to go 50. We usually give the nurses a broad range. We'll say, okay, start the patient for a fluid removal, let's say 25, and gradually up it up to 75 or 100 cc, how comfortable you are. So in that way, the nurses usually have time and they have their own comfort space and they can play around with the fluid removal gradually on these patients. Antibiotic dosage, you have to look into the up to date or literature for majority, but usually what I feel is, since you're mimicking your normal kidney function, the antibiotics majority of the times are dosed as per your normal kidney function. But there are a lot of guidelines nowadays for antibiotic dosages on CRRT, or you can actually just go look into the up to date and it will give you the CRRT dosage for a lot of these meds if needed. The other thing with the CRRT is, now remember one thing is CRRT is it's a slow continuous renal replacement therapy. It's going to be slow. So your clearances are going to be slow. Your hemodynamic stability is going to be better because you're not going to be dropping your pressures a lot. Okay, so you're not going to get good clearances. Okay, it's mostly CRRT is good for fluid removal. Now if somebody comes in, let's say is hypotensive and is hyperkalemic, or somebody comes in has poisoning and is hypotensive, the modality of choice is still going to be hemodialysis, to put them on pressors and do dialysis, because in that way you can get good clearances and you can quickly correct their electrolyte or acid base disturbances. CRRT is for somebody who are like getting volume overloaded, or you want to maintain their volume status, and those are where the thing where CRRT can help you is something like lithium poisoning. Somebody comes in, has lithium poisoning. So what you do is you initially do regular HD on those patients, bring the lithium level down, but then eventually in the body, the lithium, which is bound to albumin, is going to release, it's going to rise up. So to prevent that, you can actually use CRRT to prevent the secondary rise on of the lithium. But anytime remember is when you're doing this process, it's a very slow process with the slow blood flow, so slow dialysate, so you're going to get very slow clearances. The other thing that comes up on the machine are the alarms. A little bit, I'll go over the alarms. Now, the most common problem that we have is the alarms are going to be two types. Number one is you're having issues with your access. If you're having issues with your access, you're not being able to pull blood, or you're not able to be pushing blood. Okay, so if you're not going to be pulling or pushing, your access pressures are going to be high. That's going to be your venous and your arterial pressures. Okay, so that is one thing that can trigger the alarms. The other thing is if the filter is started to clot. Now remember, anytime you're running blood, it's not that there is always going to be a deposition of some form of proteins on that filter. Okay, so over time, as the filter keeps on running, the deposition gets on more and more, and there is a chance that the filter can start clotting. So that can also trigger an alarm. So one of the things that you can look when you're getting an alarm is looking at the transmembrane pressure. Okay, the machine will tell you what is the transmembrane pressure. It's basically the pressure difference between the arterial side on the filter and the venous side on the filter. And if there is more and more, the transmembrane pressure is going to rise. Okay, once it goes around 350, it will start alarming. And once it's around 450, that means your filter has clotted. So once you start seeing that the transmembrane pressure is rising, then one of the things you can tell the nurse is maybe they can frequently start rinsing the CRRT with saline, just to get rid of whatever substance have deposited on the machine. So one thing interesting here is what's going to happen to your access pressures if your system is clotting. If your system's transmembrane pressures are going to gradually rise, your access pressures are not going to be changed because your access is not giving any problems. So what we will notice is, so that's one of the signs is if you have rising transmembrane pressures but normal pressures, return pressure, that is normal venous, normal access pressure, that means those are early signs of your system starting to clot. Okay, now if you have high access pressures, that means that the problem is with the access. So if you have high access pressures, even then your transmembrane pressure is going to be high, because any type of a clot, whether it's an access clot, is going to make your transmembrane pressures high. But if you have high transmembrane pressures but you have normal access pressure, that means it's a problem with the filter getting heading towards clot. Okay, so the most common type we see is the problem is always the access. That is unfortunately one of the most common causes of uh, the CRRT issues. One other thing for you guys to remember is prefer to make, when you're running CRRT on the patients, the adequacy of the treatment is very important. If you're running CRRT, you don't want to disconnect. Oh, now I want to send the patient for CAT scan. Now I want to send the patient for ultrasound. Now he has to go for this. So usually it's better that plan up your whatever needs to be done, because once you disconnect the machine, you can prime it and keep running it for 3 hours only. Once it's more than 3 hours, then you have to actually discard the cartridge and you have to use a new cartridge. That is when the patient is already running on the CRRT. That doesn't mean that you have still not connected the patient on CRRT. Once you have connected the patient on CRRT, there is blood in the machine, and then you're disconnecting it. You can actually run that machine for 3 hours. After 3 hours, if the patient is not back and you cannot hook the patient back, then you have to discard the cartridge and you have to prime the whole machine again. So you have a 3 hour window. So that's why if a patient is on CRRT, you are getting an MRI or a CAT scan, just try to get it in a 3 hour window, because in that way you can actually uh, continue with the same cartridge. Otherwise, you'll have to throw away the cartridge.
The other thing I'll do, Dr. Kumar, is that if, there are a lot of disturbances and there's like, we're stopping here and there for CAT scans or whatever, or they're having issues with the filter, is then I'll, after a couple hours, come back and look at what the discrepancies between what we've prescribed and what's actually being delivered in terms of, especially in terms of our ultrafiltration. And then I'll start letting the nurse know to catch up. And I won't like say like, catch up in the next hour. So I'll say it over a couple hours, like, say we've been running at like 25 cc per kg, and we're a bit behind, then I'll say increase that a bit for the next, I'll say like, say we're like a liter or two behind, I'll say increase that a bit over a course of like 3 or 4 hours, and then I'll make sure that I myself come back and usually gets adjusted, so we're back at our prescribed rate that we initially want. Because the majority of the times, if there are disturbances, what you'll end up seeing in an hour or two after that is that there's a huge discrepancy between what we wanted to do and what's actually being done, and then now we have to play catch up.
You're absolutely right. But the other thing you have to be careful is, at the same time, you don't want to make them hemodynamically unstable. So like you say,
Right.
okay, the patient is on 25 cc's, you say, okay, let's go for 50. But now if the patient starts to require pressors, at that moment you would like to back off and say, okay, let's just continue 25, let's see. That's why you usually give them a broad range to the nurses. Like instead of putting, earlier we used to say, oh, I just wanted 25 cc's. So every time there is any change, or see, the thing here is you guys are more in the ICU compared to me. Okay, I'm not there 24 hours, so you guys keep on seeing the patient hour to hour, so you can always play around. That's why a broad range, we give a broad range, like say, okay, 25 to 75 cc's an hour, and you guys can always titrate and play around with it. So that is the whole concept here, is we want to get an adequate treatment for the patient. So it's up to you. And you don't need to call us or anything for everything, especially for our group. You don't need to keep on informing us, oh, I'm going up, I'm going down, I'm going up. It's a range. You can, the nurses, and that's why the nurses can also play with it, uh, so long as you're achieving what goal we are achieving on the
For
patient.
the ultrasound savvy people, like what I'll do is, just like how when we use like serial LVOT VTIs to assess like what is the best intervention that we're doing to get the best cardiac output, I'll do that. So if I make a change on CRRTs, I'll come back into the room and see how it's affecting their hemodynamics based both on their serial LVOT VTIs and their VEXA scan. So I'll use a combination of both. I want to minimize congestion. I want to maximize cardiac output. So if I start taking more fluid off and I see that their VTI is going down, I'm thinking, okay, the patient's likely becoming more hypovolemic, and that's where the cardiac output is going down. So then what I'll start doing is I'll start decreasing, coming back on the prescribed dose. And then if I see that if they can tolerate it, for example, their VTI is like recently 24, 25, then I'll start to go up on the fluid. And if their VEXA score is high, and I'll start to get more fluid off. And then, I'll do it for a couple hours. If I feel like I need to continue it, I'll let the nephrologist know. If I feel like it was just a temporary thing that I have to do, and I do their VEXA scan again and do it for like a 3 to a 1, then I don't need to make, I can go back to what the original prescribed dose was.
So the other thing is, access wise, you technically have to use a permacath. Can you use an AV fistula or a graft? You can use an AV fistula or graft. The problem is it's not encouraged. A couple of things with it, because the needles stay for 24 hours. So it has to be monitored. So somebody has to be sitting there continuously, because if it gets dislodged, patient is going to bleed to that. So that's why, because with the permacath, it's a fixed needles. Number two is, if you leave the needles long enough, then the chances of forming a pseudoaneurysms are very high. That's why using the fistula or the graft is not recommended when you're doing continuous renal replacement therapies. Any particular site you can use, doesn't matter whether you use the groin or the IJ. All the institutions have their policy all regarding to infection control, this and that. So so long as you're maintaining a clear environment, the groin catheters also can stay for at least a week. There's not a big.
Do you have a preference in terms of using a double lumen if you're going femoral, or a trialysis is fine?
Doesn't matter. It's we have tried both. We have used double lumens. We have used trilumens. We haven't found much. The only thing sometimes they say is, when you're giving a third agent to the trialysis, because the two ports on the catheters are close by, there's always a high chance that the medicine may just get reserved. So that is the only thing they sometimes say about it. So, but other than that, it doesn't matter whether you use technically. That's why the literature now, I don't know what recently, but that's the last I knew was they were preferring to use double ports instead of trialysis. So, but I think we have both double and triple ports here.
Speaking of real quick, like in terms of access, it varies by a lot of people, but I actually might end up changing my practice. So when you're talking about like where you're placing and the size of the length that you're using, so if you're doing groin, you should always use a 24 centimeter. If you're using, you're going in on the right IJ or subclavian, the actual kit, the company recommends 15 for the trialysis. There are papers out there that see decreased incidence of the catheter coming out and of having inadequate flow rates, like your axis return arms going off, if you use a 20. And then for the left side, always a 20. And you can place them on the left side. I mean, I know it's kind of like scary that when you get the X-ray, because it's not as bendable when you're using the trialysis catheters, you will see that like your IJ from the left side will just kind of go diagonally instead of the catheter kind of like curving along the normal anatomy. But as long as you place it carefully, you will see that you put it on the left side.
And if you're going to go subclavian, make sure you're paying attention to what the BUN is at and see if they need a dose of DDAVP. Obviously, that bleeding is going to be difficult to control.
Yeah, I mean, I've looked at literature for DDAVP. I know there's quite a few surgeons out there that will use it for procedures, which is where it's been studied. But I mean, we've had patients that have BUNs like 130, 150. You give DDAVP an hour before, and I don't see any difference in bleeding compared to when I do it without. And it's just, I don't find it as effective because, yeah, I mean, it's uremia. The damage is still going to be there even after the DDAVP.
The thing here is, Alok, you need to understand is that only treatment for uremic platelets is dialysis.
Right.
They have studied everything like DDAVP stuff and that. The problem is, what is DDAVP going to do? It's not going to develop clean platelets. It's all going to bring the platelets, but those platelets are already uremic. So technically, you're giving just a pat on your back that, oh, I gave him DDAVP, but technically the DDAVP is not doing. The only thing that's going to help those platelets are dialysis.
I think that's all fair, but at the end of the day, if their BUN is 130 and you have nothing else to do, there's no harm at this point. They're already on urine.
There is nothing. It's the same thing. Like, should we give what do you call it? An acetylcysteine for contrast-associated nephropathy? There is no
Doesn't
harm.
work.
Yeah. So the thing is, yeah, you can go ahead and give it, but it's not going to harm you. That's it. Only thing is, people should know what dosage to be given and how to be given. The problem I see is a lot of time people don't know how to give it.
I believe it's
Hey, it's Joanna.
Said, oh, go ahead.
Sorry. Go ahead, Alok.
I think on up to date it says there's no efficacy greater than 140, but it's lower than what we use for like clamping for it's much greater than what we use for like clamping for hyponatremia.
Yeah, usually it's like 24 to 28 mics times one dosage IV. I think it's like 0.5 or something units per kg, something like that. Usually it comes down to round about 24 mics.
I think typically we use 0.3 to 0.4 in our system.
0.3 to 0.4. So yeah, it's like 0.5 roughly, easy to remember. So it comes to around like 24 mics. The minimum if you ever want to put is just go ahead and type 24 mics.
Saying anything above 40 doesn't have
Any benefits? Yeah, Joanne, you had a question or something?
Yeah, I not so much a question, just somewhat of a comment, something that I've heard at least while I've been here at Atlantic Care. The preference for sites for a hemodialysis catheter, usually they avoid subclavian, and the thought process, at least here, is that they try to preserve that for patients who may end up needing long-term access. So that would be your last option for a dialysis catheter. Do you
No,
feel
you're
the same way?
absolutely right. You are absolutely right. Subclavian is, there are two issues. Number one, the long-term dialysis. Number two is the bleeding. You won't be able to find it easily and it's very hard to control. So that's why, like anytime, if you're thinking the patient is coagulopathic or very high BUNs, go ahead and use a groin.
Next thing to keep in mind in terms of practice pros is like, kind of just touching on when you're concerned about infections is that because of the temperature of the fluid, majority of these patients should have a lower temperature. So keep in mind if the patient is spiking a fever, you're going through the dialysis fluid, they're not going to be able to mount a febrile response. So, the central measures of temperature are far more accurate than your peripheral measures of temperature. And so kind of keep an eye out for that. CRRT may be masking any present fevers. Keep in mind that if you are, I don't know, Dr. Kumar, if you want to kind of talk about when we should be considering giving blood back in terms of like if we're having issues with the CRRT machine, if the filter's been changed a few times, and how we can prevent loss of blood.
So to be honest with you, the only thing is anticoagulation. If the patient can get heparin, that would be the best thing, which prolongs our filter life. The other thing is going to be using pre-filter saline, which can dilute it up and prevent the clotting. Other than that, we don't use any cited, and there's no other method. The access should be good. If you are having high access pressures, then there's a high chance that your CRRT is going to clot. So good access, anticoagulation, or pre-filter saline, those are the only few things we have to prevent clotting. Once they clot, yeah, it's around, I think, 250 to 300 cc that's in the system has to all be thrown away, and you have to monitor the HNH on these patients.
Yeah, if you feel the blood is good, you technically can give it back. So what you have to do is you have to clamp your access filter, inject that heparin through, clamp it, and then you hang a saline bag through where the access tubing was connected. You make sure there's no air in it, then you run it through the filter, and then you allow all that remaining blood to come back into your return filter, and then you clamp off your return filter so that you minimize the loss of blood. And most nurses here do practice that when ending CRRT.
So it's done in both, whether it's even in your regular hemodialysis and your CRRT, the nurses try to minimize the blood loss. There are protocols for it. The other few things that you guys have to be careful about with the CRRT is when you're running CRRT with hypothermic protocols, because you need to maintain the temperature around 32 on those patients. And I think you have a dial back in the CRRT machine, and I think the minimum it goes to around is around 34 or something. You have to check it out. So what sometimes you do is you can actually put ice packings on the post line. So you can cover it with the ice so that you're able to at least minimize the temperature loss. So you can cover it with ice, what it return back to the patient. So that is one thing you can do. You can, I don't know, I don't think so we do about using the dialysate, cold dialysate. I'm not very sure about it using but you can actually turn the machine temperature to the lowest possible, what it is. And I think it's around 34 on the back of the dial. Other thing is your effluent should always be clear or like slight yellowish in color. There should never be any blood in it. So anytime if you notice any blood in the effluent, that means that the filter is compromised. That means there is a breach, and that is a high risk for contamination. So anytime the fluid is, you have to immediately stop the system, and then you have to prime it with a new cartridge. In the past, we used to take that cartridge and it used to be sent to the manufacturer for analysis, but nowadays they don't do it because it's a biohazard, because it has blood in it. So what they do is now they take the lot number and stuff and then send it to the company just to make sure that there's no other issues with the similar lot. But if anytime there is any blood leak or anything in it, it has to be immediately stopped and you have to put a new filter in.
And on our end, if you're concerned that you don't want to change the patient, if you're questioning like maybe the fluid just a little bit orange or a little bit pink,
No, it's
you
not
can.
orange pink. That's different. If it is blood, if there is blood in it, if it's pinkish or reddish, then you have to. Now, the thing is, sometimes you guys use methylene blue. If you give methylene blue to the patient, the dialysate is going to come out as like bluish in color. The effluent
Yeah.
is going to be. But anytime there's blood in it, it is pinkish or reddish. That is, you have to check it out because that means there is a breach in the filter. That means the dialysate and the blood are coming in contact with each other.
Yeah,
And
you can
there's a
always check you can always analyze the effluent fluid and send it to lab and then put it as a body fluid and then have them look for red blood cells because
Yep.
it shouldn't be in the effluent fluid.
About the cartridge life maximum I think is around 3 days or 4 days. Yeah, they usually have the time on the machine. It all depends on how sick the patient is. We have had
So,
patients where they have lasted long. We have had patients where, yeah, it didn't last long.
so final two things, unless anyone else has any questions, is how to assess or how to deal with CRT in a patient that's you feel like is about to crash. So that the patient has either ventilator asynchrony. You see that there's concerning hemodynamics, changes in mental statuses. That's very acute. I've seen people recommend stopping CRT, but try not to stop CRT. Instead, just try and come down on your ultrafiltration because you want to once again minimize time off dialysis. Majority of the times, and this can be confirmed with ultrasound as well, is that if you come off your ultrafiltration, is that basically pull less fluid, is that the patient's hemodynamics will stabilize, and then you're buying yourself time to properly assess the patient. In contrast to a coding patient, what you also want to do is that there's one thing is that like a patient that's coding and a patient that's on CRT, good compressions does not go well with good CRT, right? Because you'll have all those access and return alarms because of obviously pressure changes because of that good compressions. But the important thing to address here is that if you're going to stop CRT is to give that blood back. Make sure there's no compromise in blood being lost, especially in a coding patient.
Yeah, you're absolute because the thing here is crashing and coding two different things. I totally agree. Is if the patient is coding, just ask the nurse to return the blood, stop the CRRT machine, actually put the machine in prime. You have 3 hours for the machine to be reconnected. So you can just ask the return the blood and put the machine on prime. If a crashing patient, it depends. If not, yeah, go back, cut back on the dialysate flow, cut back on the blood flow. You may just even do it like 150 or from 250 or 200. Just back off and just make the ultrafiltration zero. Keep it even for now, or just make it zero for now to get a regain the hemodynamic stability, and then you can always restart the patient because once you start coding the patient, your CRRT machine is not going to run and it will keep on beeping, beeping, beeping. So it's better during that time is just put the machine into prime.
Thank you, Dr. Kumar.
Okay, guys, thank you. Yeah, I'm anyways here. If you guys have any questions or anything, you guys can always reach out to me, and I'll actually look into it about your blood and fluids, which can be given in the post CRRT line. And I'll try to also have, because a lot of things what we do like the CBVHD, DF and everything, they're more done with the Gambro machines, the Braun machines. Those are very complicated machines. The Fresenius ones is a very simple and easy machine, and that's why a lot of institutions have it, is because the ease with what you do it. They do have a CRRT conference. If you guys are anytime interested, it's a fellow conference. I think it's in Atlanta. University of Alabama does it. So they have a 2-day or 3-day conference there. But I'll have the CRRT guy maybe come in and talk to you guys about the machine, explain you guys a little bit more alarms and everything. So we'll try to arrange that lecture for you guys with the CRRT, with the Fresenius guy. Okay.
Anyone have any questions?
Dr. Kumar, do you have any influence on the type of catheter